Hello, today we are going to talk about atrial fibrillation. So what we will cover in this lecture is definition. What is atrial fibrillation, epidemiology, classification of it, pathophysiology, risk factors and etiology, signs and symptoms in which the patient is presented with, diagnosis and treatment approach. So first, atrial fibrillation. It's one of the most common heart rhythm disorders with an estimated global prevalence in 2019 of almost 60 million persons, with incidence cases doubling every few decades. It's a supraventricular arrhythmia with an uncoordinated atrial activation, which results in a loss of effective atrial contraction. And this is presented on the ECG by the absence of discernible and regular P waves and irregular activation of the ventricles, and it results in no specific pattern of the RR interval. So, for classification, atrial fibrillation is classified into four classes. First, we have a first diagnosed atrial fibrillation. It means that the patient has not been diagnosed before, regardless of the symptom status, temporal pattern, or duration. Paroxysmal atrial fibrillation, it means that the patient had atrial fibrillation within 7 days, but it terminates spontaneously or with the assistance of an intervention, and we are going to talk about this later in the treatment approach. And the evidence suggests that most of the self-terminating paroxysms, they last less than 48 hours. Now for the persistent atrial fibrillation. It has episodes which are not self-terminating, and many intervention trials have been used during these 7 days as a cut-off for defining persistent atrial fibrillation. And long-standing persistent atrial fibrillation is defined as a continuous atrial fibrillation of at least 12 months duration, but the rhythm control strategy is still a treatment option in those selected patients, and that's how we distinguish it from a permanent atrial fibrillation. So for the permanent atrial fibrillation, it means that there is no further attempts at restoring a sinus rhythm, of course with a shared decision between the patient and the physician. Moving into the etiology or the risk factors of atrial fibrillation. So there are a lot of modifiable and non-modifiable risk factors. It includes advanced age, obesity and reduced physical activity, congenital heart diseases, or underlying heart pathology like valvular disease, coronary artery disease, structural heart disease, atrial ischemia, increased alcohol consumption, hypertension, it can be either systemic or pulmonary hypertension, endocrine pathology like diabetes, either type 1 or type 2, pheochromocytoma, and hyperthyroidism, hypothyroidism as well, hyperparathyroidism, genetic factors, neurological disorders like stroke or subarachnoidal hemorrhage or hemodynamic stress, pulmonary embolism like left ventricular dysfunction or mitral or tricuspid valve pathology, obstructive sleep apnea, inflammation within the heart, myocarditis, pericarditis, or any condition that leads to inflammation, stress, damage, or ischemia, which affects the anatomy of the heart and results in the development of atrial fibrillation. Of course, in some cases, which is very rare, the cause can be iatrogenic. Now, moving into the pathophysiology. So, mainly atrial fibrillation. Let's start first with the action potential within the normal heart. So the normal heart includes four chambers, and the normal action potential, it starts from the SA node and it passes to the AV node, and then it passes down to the ventricles. But during the atrial fibrillation, there is discoordination of this pathway. And this coordination can be due to, for example, presence of another foci within the atria, other than the SA node, which will start firing an action potential and generating this atrial fibrillation. And this foci, usually it's located near the pulmonary veins. Or it can be, for example, due to another mechanism or another risk factor or another pathology. Let's just say, for example, valvular pathology. For example, like mitral regurgitation, which will lead to increase in the stress within the atria, and it leads to its dilation. And this stress of the atria, it leads to a change within the electrical properties of the cells located there. For example, one cell will have a faster conduction than the other cell, or one cell will have less refractory period than the other cell. And this change it will create multiple electrical conductions which are not coordinated, and it will lead to this irregular rhythm. When one of these action potential activity passes through the ventricles, that's when we have the QRS complex presented on the ECG. And when the blood stagnates in that period within the atria during that time of discoordination, it increases the risk of ischemic stroke and thromboembolism, and that risk is increases, of course, with other risk factors and other comorbidities that the patients already have. So for the symptoms, the patient usually, when he presents himself into the hospital, it can be either a patient with very small, mild symptoms, or it can be severe symptoms. So the symptoms can be variable and broad, and not just typical palpitations, as we know that the atrial fibrillation mostly is presents with palpitations. Patients also sometimes they can be asymptomatic, even though it's so rare, although like 90% of patients will have symptoms. So these symptoms they include palpitations, as I said. It can be shortness of breath, fatigue, chest pain, dizziness, poor exercise capacity, anxiety, syncope, depressed mode, and disorder mode. So now moving into the diagnosis. So when we have a patient presenting with these symptoms, first of all, we have to do a certain workup of all patients. We have to talk to the patients and check for the medical history to determine for atrial fibrillation pattern, family history, the presence of comorbidities, to assess for risk factors and thromboembolism and for bleeding. We have to do a 12-lead ECG and blood tests with full blood count, kidney function, checking serum electrolytes, checking liver function, if the patient has diabetes by checking glucose level and glycated hemoglobin, checking also thyroid function tests, and doing a transthoracic echocardiography. In some selected cases, we have to do Holter of ECG monitoring to check for the atrial fibrillation burden and ventricular rate control. So what is the atrial fibrillation burden? It means that on an ECG record of 24 hours, sometimes we have some patients when we do, for example, Holter monitoring for assessment of another heart condition or another heart pathology, when we are checking it, we find that there is a small period of time when the patient is presented with atrial fibrillation. This period of time, small period of time within all this record, is called atrial fibrillation burden. We have to check exercise ECG to evaluate also for patients with antiarrhythmic drugs with signs of ischemia, race control as well. We have to do some further blood tests for investigation of cardiovascular diseases, for example, like NT-proBNP. We can do transesophageal echocardiography for assessment of left atrial thrombus and valvular diseases assessment, coronary CT angiography, ischemia imaging for suspected coronary artery disease. We can do also cardiac MRI for the evaluation of cardiomyopathies and to plan also for interventional procedures. We can do also in certain cases brain imaging and cognitive function assessment for cerebrovascular disease and dementia risk assessment. Now moving into the treatment. So for the treatment, of course, we have to do a management of risk factors and comorbidities because they increase the risk of severity of atrial fibrillation with its risks of stroke, thromboembolism, and all of that. Then we avoid the stroke and thromboembolism. How we do that? For oral action anticoagulants, we have two options. We have either a direct oral action anticoagulant or vitamin K antagonists. Before that, we have to check the CHADS-VASc score. We are no longer using, before it was CHADS-VASc score, which includes also the sex, like male or female, risk, but nowadays in the last recommendations of cardiology, we use only CHADS-VASc score without the S, which is present in the sex of the patient. So for C, it presents chronic heart failure, and we give that 1 point. For H, it presents hypertension, we give that 1 point. A, it presents the age more than 75 years, and we give that 2 points. D presents diabetes mellitus, either type 1 or type 2, and we give that 1 point. And S for prior stroke, transient ischemic attack, or arterial thromboembolism, and we give that 2 points. And for the V, it presents vascular disease like coronary artery disease, angina, or for example, if the patient has a history of revascularization, or we have a confirmed diagnosis of coronary artery disease on angiography, peripheral vascular disease including intermittent claudication, uh, prior revascularization for peripheral vascular disease or other conditions, and we give that 1 point. And for last A, it's age from 65 till 74, and we give that 1 point. So for the CHADS-VASc score, when it gives us 2 points, we have to give DOAC or oral action anticoagulant. When it's 1, it means that it should be considered. When it's 0, it means that there is no risk of stroke and thromboembolism. So we have, as I said, two options. We have the direct oral action anticoagulants, which is the first recommendation. So they are mainly used because of their benefits, that they are easily used in clinical practice. We don't have to keep checking on the patients with the INRE, and also it has shown in multiple clinical trials that it's much better than the vitamin K antagonist in reducing the risk of stroke and thromboembolism, and also there is decreased risk of bleeding, of intracranial hemorrhages, and so on. While, for example, if the patient has severe mitral stenosis or mechanical valves, then we cannot use a direct oral acting antagonist, and we have to use a vitamin K antagonist. But when we have to use vitamin K antagonists, like warfarin, for example, we have to keep checking periodically in error, and it should be between 2 and 3. Now we move into heart rate control and rhythm control. So first of all, in firstly diagnosed atrial fibrillation, electrical cardioversion is recommended if the patient is hemodynamically unstable. For the rate control, if we have a patient with heart failure with reduced ejection fraction, which means less than 40%, we have two options of rate control: beta blockers or digoxin. Mostly we use beta blockers, and the most used beta blocker is metoprolol citinate. If we have a patient with preserved ejection fraction or mildly reduced ejection fraction, which means anyway it's more than 40%, then we have the options of beta blocker, digoxin, verapamil, or diltiazem, and also combination treatments can be considered or should be considered when necessary. For paroxysmal atrial fibrillation, we have the same race control strategy, which means we have to check the ejection fraction, and then we check what options we have for race control, beta blockers, digoxin, and so on. For the rhythm control, the option of antiarrhythmic drugs includes, because in the rhythm control we have two options, either the usage of antiarrhythmic drugs or the usage of ablation, the option of ablation. So for antiarrhythmic drugs, it includes, if the patient has a reduced ejection fraction, we give amiodarone. And in a stable patient with mildly reduced ejection fraction, we give either amiodarone or dronedarone. And for a patient with a minimal heart pathology, then we can give propafenone, flecainide, or dronedarone. The option of ablation includes either surgical ablation or catheter ablation with a shared decision making, of course, between the electrophysicians and the surgeon as well. And of course, we check also with the patient's wants. We give the options to the patients. For persistent atrial fibrillation, of course, we have the same race control strategy. For the rhythm control, we give electrical cardioversion if patient is hemodynamically unstable. And also we have the antiarrhythmic drugs, the same as in paroxysmal atrial fibrillation, is that the difference here is that catheter ablation is may be considered, which means it's not the first recommendation of the treatment. So it may be considered in the beginning, but we start first with first recommendation, which is the antiarrhythmic drugs, unless when the patient, for example, has converted into sinus rhythm and after that he will have recurrent atrial fibrillation symptoms, then we recommend the usage of catheter ablation, or it can be another type of ablations like endoscopic or surgical ablation. It should be considered as well. For the permanent atrial fibrillation, the same approach of treatment. It's just that for severely symptomatic patients with multiple hospitalizations of heart failure, atrioventricular node ablation with a cardiac resynchronization therapy should be considered as well. There is also another option of treatment which is called left atrial appendage occlusion. It's an option for patients with contraindications to anticoagulation from the beginning and a high stroke risk. It's the left atrial appendage. It's actually a small pouch in the wall of the left atrium, and it's the most common site for a thrombus to form. So, the left atrial appendage occlusion or closure involves inserting a catheter into the femoral vein, feeding that through the venous system to the right atrium, and puncturing the septum between the atria to access the left atrium. Then a plug is placed into the left atrial appendage, preventing blood from entering that area. Now we have some dosage recommendations. So for DOACs we have apixaban. Apixaban, it depends, like we choose depending on what drug is available in the hospital. So it's not like we prefer something else than the other, but mostly used is apixaban from what I saw. So apixaban, we have 5 milligrams 2 times per day, and we have also, that's the standard dose that is given to the patients, and we shouldn't reduce the dose unless there is some specific criteria uh, for reduction of the dose. For example, for apixaban, we have 3 criteria, and 2 of them should be available to reduce the dose of apixaban into 2.5 milligrams, and we give it 2 times per day. So the criteria includes age, which should be more than 80 years old, body weight less than 60 kilograms, and serum creatinine more than 133 millimole per liter. So when there is, for example, 2 from these, it means 2 out of 3 are needed to reduce the dose. Then we have dabigatran, another option, 150 milligrams 2 times per day, and edoxaban 60 milligrams 1 time per day. Each one of them, it has certain criteria for reduction of the dose, and unless these criteria are not met, then we cannot reduce the dose. For the race control, we have and one more thing, for the vitamin K antagonist, the dose, of course, it changes with inere value. So the patient should periodically check the inere, and after that we either reduce or increase the dose. Now for race control examples, we have metoprolol succinate. The dose is 50 till 200 milligrams per day. Digoxin, either we give it intravenously or oral. Intravenous, we have 0.5 milligrams bolus of 0.75 to 1.5 milligrams over 24 hours in divided doses, or per oral use till 0.25 milligrams once daily, starting from 0.0625 milligrams. For verapamil, uh, we start with orally 40 milligrams twice daily till 480 milligrams extended dose once daily, or we can give IV bolus 2.5 till 10 milligrams over 5 minutes. Duration control. Examples of drugs, we have amiodarone. For amiodarone, we have intravenous from 900 to 1200 milligrams over 24 hours, or we give 200 milligrams orally 3 times per day in the period of 4 weeks. And in the long term, after that, we can give 200 milligrams orally once daily. Propafenone, we have initially we should give 450 to 600 milligrams, and long term 150 to 300 milligrams 3 times per day. Flecainide, initially 200 to 300 milligrams, and long term 50 to 150 milligrams 2 times per day. And that's all for today. Thank you. I hope you like this lecture.